Hi, my name is Bijal Shah from the Moffit Cancer Center. Thank you for inviting me to share the 2-year follow-up data from the ZUMA-3 trial. This is a trial of CAR T cells targeting CD19 with a CD28 co-stimulatory domain in adult patients with relapsed and refractory B-ALL. In the 2-year follow-up, we wanted to do a couple of different analyses. The first was to, again, with longer follow-up, ask the question, were we seeing any impact of allogeneic stem cell transplant? When we did censoring for allogeneic transplant versus non-censoring, looking at duration of remission, interestingly, we did not see a significant impact for patients who were in CR. For those who had a CRI, there was a slight decrease. Again, these weren't statistical comparisons, but we did see a slight decrease among these 8 patients with a DOR that went from 8.7 months when censoring to 5.7 without censoring. Again, hard to know the significance of that. I'll come back to the transplant issue in a couple of seconds here. Looking at the total group, interestingly, we saw the opposite trend. So combining those with CR or CRI, this is 39 patients. The median DOR was 14.6 versus 18.6 months without censoring. The take-home message here is, I think the data show the CAR T-cell therapy to be durable. There is some impact of transplant. When we tried to break this down in a different way, actually just doing a simple consort diagram and following patients, I think the most fascinating thing we saw was that 6 out of the 10 transplanted in a CR or CRI remain in ongoing remission. And I think that was an unexpected observation. I would argue, particularly for a relapsed and refractory population, similar to the one we enrolled. So why are patients doing so well? I think one possibility is we over-transplanted. It's possible that patients who had a deep remission would have stayed in remission independent of whether they had the transplant or not. The other possibility is the depth of remission afforded by CAR T allowed for the transplant to work more effectively, despite being in this more heavily relapsed and refractory group. If we compare our outcomes to those who did not have a transplant, so 23 patients did not have any subsequent therapy and were simply followed after CAR T-cell immunotherapy. We have 6 in ongoing remission without any additional therapies. That's 6 out of 23. Again, small numbers, and includes those who had both a CR with incomplete count recovery as well as those who had a true CR. So, again, a little hard to know whether the transplant, whether we really answered the transplant question here. And so, my colleague, Dr. Olawale, also presented actually survival plots, so Kaplan-Meier survival curves, looking at transplanted versus non-transplanted patients. And I think that, I'll let him describe the data further, but it's certainly very intriguing. This was not a landmark survival analysis. This simply looked at survival of patients who were transplanted versus those who were not. But again, interesting that those who are transplanted are doing as well as they are. Coming back to this ASCO presentation, we also looked at overall survival, and we looked at this both in the strict ZUMA-3 phase 2 cohort, as well as a combination of the phase 1 patients treated at the phase 2 dose, so the 1 times 10 to the 6 per kilo cell dose, in combination with the phase 2 patients. And so when we looked at just the phase 2 alone, we had around 25 months of follow-up, so around 2 years or so. And with that, we saw a median overall survival of 26 months for patients with a CR or CRI. And I think this is really outstanding. If we look at all treated patients, so now independent of whether they achieved a remission, the median overall survival was 25.4 months. And I think that just speaks to the fact that the majority of patients achieved a remission. When we pool the data, the phase 1 and phase 2 data, so now we have longer follow-up here, the median overall survival for patients with a CR or CRI was 47 months. And I want to pause there for a second because I didn't even believe the data when I saw it. I think that is truly remarkable. We transplanted only 10 of the patients on the phase 2, and trying to recall from the phase 1, but it wasn't a substantial percentage of patients who were transplanted on the phase 1, particularly at this 1 times 10 to the 6 per kilo cell dose. And we're seeing really survivals that I think would not be expected for a relapsed refractory ALL population. And so I do think that the CAR T-cell therapy is bringing something extraordinarily important to these patients. We wanted to dig a little deeper and try to understand how age and bone marrow blast burden impact outcomes. We had seen in the phase 2 and in the phase 1 of ZUMA-3 that patients with high tumor burden, particularly those with greater than 75% blasts, had inferior outcomes. So we confirmed that looking at overall survival. And so for those patients who had greater than 75% blast, the median overall survival was 14.2 months. When we compare that to those at lower blast burdens, essentially the median overall survival was not reached, except for one group, the 10 patients who had between 5 and 25% blasts. And again, I think one of the challenges here is follow-up. I suspect with longer follow-up, we'll sort of see all of the groups kind of come together, and you can see that visually. I don't have the survival curve to show you here, but I suspect all the groups with less than 75% blasts are doing fairly similarly, which is outstanding. By age, we introduced saw 2 groups who seem to do well. Now, again, I want to highlight the survival curves largely overlap, so I don't want to make mountains out of molehills here. But when we look at the groups, we don't see those over 50 or those in the 18 to 25 year range reaching the median estimate for overall survival. So in those 18 to 59, the median overall survival was around 25 to 26 months. So I think these data are showing us 2 things, really. One, that CAR T-cell therapy can be safely delivered to those patients who are older. And I think that's a very important observation. For the 18 to 25 year group, we purposely called out this group. And if you look closely at the abstract, there are 2 groups, one that's 18 to 25 and one that is 18 to 39. The 18 to 25 year olds do, I think, comparatively well to what you might see with tisagen laclusel, which is the other FDA-approved product for these patients. And so that's why we wanted to call out these 12 patients just to show that they're also doing quite well from a survival standpoint. When we look to the ages and the blast burdens to try and understand how this impacts toxicity, we did not see any clear trends. And for me, this was a surprise. I would have expected those who were over 60 in particular to experience more in the way of neurologic toxicity or ICANS. Similarly, I would have expected those with very high blast burdens to experience more significant CRS. But we couldn't clearly see that. Now, I keep emphasizing the numbers are small, and they are. So it's a little bit hard to dig too deep into the data to say, that we can now ignore blast burdens or we can ignore age when we make our treatment decisions. But it's certainly surprising that, we didn't see anything really apparent jumping out at us. The other thing I think it helps to emphasize is the threshold for high tumor burden. So, one of the caveats for ZUMA-3 is we did require greater than 5% blasts at enrollment. Now, we did have 5 patients who, after bridging therapy, were able to reduce that blast burden to less than 5%. And when you look at these patients, only one experienced grade 3 or higher CRS, and only one experienced grade 3 or higher ICANS. And so I think taking this data set and taking some of the other data sets that have been developed, including the pediatric real-world consortium data from Leora Schultz and also the multi-center analysis from Nurali Shah, I think we can say that 5% blasts is a very reasonable threshold for high tumor burden in ALL, and with patients under that threshold outperforming patients who have greater than 5% blasts. And so it tells us, not that patients who have higher blast burdens won't benefit. We can still see benefit, but if we're going to talk about who derives the greatest benefit, I think it tells us we need to start thinking about how we bring CAR T-cell immunotherapy into MRD settings, into low blast burden settings, so that we can see both a lower toxicity and improved overall survival. So with that, I want to say that's really sort of summarizes the data that we presented at ASCO, but I want to put again another plug for Dr. Olawale's presentation of the ZUMA-3 data at EHA, where, as I mentioned previously, a more in-depth analysis of the impact of allogeneic stem cell transplant, also an analysis of prior blinatumomab exposure and whether or not or how that may have impacted outcomes on ZUMA-3. With that, thank you.